Okay. All right, so there's your definition of what a joint is or what an articulation is. So pretty much predominantly, it's going to be a place where bones are going to connect with one another. But we're going to see in this chapter now we're going to see a couple other types of connective tissue or structures that also will make up a joint. Like, for example, your teeth, right? How they insert into the mandibula, all right, or excuse me, not mandibula, the mandible and the maxilla, right? We're going to see that that is a type of a joint called a Gomphoses. And so you'll see not necessarily always having a bone to connect to another bone. You might see cartilage. So for example, your spine, the intervertebral disc joints there. So in between each of the vertebrae in your spine, you have a disc. And so that disc is made of cartilage, and that also forms a joint. So the study of joints is called arthrology. And also, when we're discussing this, it's kind of important that you kind of understand this concept. When we're studying joints, we're going to classify them, right, based on their anatomy and physiology, or like it says there on the board, we're going to classify them by their structure, again, anatomy, function, physiology. So that's how we're going to discuss some of these classifications here. So the first type of classification that we're going to use to discuss, all right, our joints are going to be structural classes. And so we have three types. Okay, so fibrous, cartilaginous, and synovial. And so the first type there, the fibrous, right, you're going to see some sort of dense connective tissue. It could be dense irregular connective tissue, dense regular connective tissue, all right? But what we're seeing is a very strong type of tissue that's going to hold, all right, bones to one another. So we kind of saw that with your suture joints. All right, the coronal suture, the lambdoid suture, right, the squamosal suture, all of those joints up in your skull, right, those are going to be fibrous joints. They're held together by a dense connective tissue. Cartilaginous joint, that's easy because it even says the word in it to describe what type of joint it is, cartilage. So you're going to have bones that are joined together by cartilage, and that was basically what I just described to you in regards to the intervertebral disc joint. So we've seen that in the spine. And then finally, we have the synovial joint. And these make up a significant number of joints in your body. And so you're going to see a synovial joint is going to be a joint that has a capsule that covers the joint space, and it's going to have fluid inside of it. And that fluid is going to be the synovial fluid. And we'll talk about, what its purpose is and what it does. Right, so those are your three type of structural classifications. So fibrous, cartilaginous, and then our synovial there. All right, then the other type of classification is going to be functional. And so we have our three types for the functional here. We have synarthroses, ampharthroses, and diarthroses. And as we move from the top of the screen towards the bottom of the screen, we're going to increase the mobility of the joints. So synarthroses are relatively non-movable or immobile joints. So they don't move very much. So there's two types. You can have fibrous and cartilaginous. Then our ampharthroses, now we're starting to get a little bit more movement in there. Same type of thing. We're going to see fibrous and cartilaginous joints are going to fall into this classification. And then finally, the diarthroses. These are the joints that are freely movable. They make up a significant number of joints in your body. And so pretty much all of the synovial joints, that means all of the fluid-filled capsule joints these synovial joints are going to be diarthroses, relatively movable, or you could say freely movable joints. So those are your three functional classifications here. So one of the things that when we deal with joints, and for those of you that are going into physical therapy or personal training or whatever, right? If you're dealing with skeletal system, you're going to deal with some of these concepts up here. And the last one is a very important concept, and I'll start with that one first, all right? There is an inverse relationship between mobility and stability. That is a very important concept to understand. An inverse relationship. We saw another inverse relationship back in chapter 2, Remember we were learning about the pH, right? And so as pH value decreases on our pH scale, so you have a solution that has a pH of 2 or 3, the hydrogen ion concentration increase. So that's an inverse relationship. If you increase one, you decrease the other and vice versa. So here, when we're talking about stability and mobility, right, we have another inverse relationship. So for example, if you increase the stability of a joint, then you're going to decrease the mobility. Let's think about the suture joints in our skull. Would you say those are highly mobile joints? No, right? You're not, your skull bones aren't moving around, right? Okay, so they are low mobility, but you better believe they're as stable as all get out. I mean, how many people do you know that's ever dislocated one of their cranial bones? I've never met a single person that's ever dislocated a cranial bone. So think about it, all right? So they're highly stable. They don't move around really. There's a little bit of slight movement, but hardly any, okay? And so they're highly stable, low mobility. Now, let's switch that. Your shoulder joint, okay? Specifically the glenohumeral joint. That's where your upper extremity attaches on to, all right, your glenoid cavity there. So that joint is really mobile. Right? It's actually one of the most mobile joints in your body, but you're more prone to dislocate. You probably met people that have dislocated their shoulders. All right. So keep that in mind, that inverse relationship between mobility and stability is one increases, the other one decreases there. So when we're looking at our ranges of motion, we'll see in some joints we barely have any. And then in others, we've got a lot. Right? And what determines this? The actual anatomy of a joint. So the structure of each joint is going to determine how stable or how mobile a joint is. Right? So your function is going to follow the form. Right? So your structure dictates if there's a lot of mobility there, or a lot of movement there, or if there is a little mobility there, and and then that also holds true for stability. So this picture here, figure 9.1, is just showing you, all right, on this sliding scale here on the left, as you go from a relatively stable joint like the suture joints there, you're not going to have a lot of movement. And then when we get down here to the glenohumeral joint, right, you'll see a lot of movement, but not much stability there. So well, this is usually where I say, you're going to probably see this on a test, right? Well, you're not going to see it on a test because we're not testing you on this, all right, this semester, right? But kind of keep that in mind. That is an important concept to understand there. So let's start off talking here, right, about some of the joint types. We'll start off with the fibrous one, right? So fibrous, think of fibers. Protein fibers is usually what I like to think about. But here, these bones are connected by dense regular connective tissue. Essentially, ligament or tendon-like material is holding two bones together. And so those joints are very, very strong. Problem is, all right, they're not going to have much mobility there, right? Because they're either immobile or slightly mobile. So there's no joint cavity in this. Why? Most likely it's because the fibrous tissue is filling any space inside of that joint, holding those bones together. So you have three types up there: Gomphoses, Sutures, and Syndesmoses. I hate to say it, this is just memorization. I wish there was an easy way to get around this stuff, right? But the three types that I want to talk to you about are Gomphoses, Sutures, and Syndesmoses. So for who here is going into a dentistry or oral hygiene of some sort? Okay, so this first joint type here is the Gomphoses. This is the tooth joint, the peg and socket joint. So if you're going to be going into the dental field, you're going to be seeing a lot of this. And so you can literally see here up on the screen. Here you can see how the tooth itself, our peg, sits into this joint space here, our socket, and the picture here is of showing the mandible. So you can see how that tooth fits right in there. And so what holds it in, and this always fascinates me, because you have these small little points of attachment here. Right? If you guys see those periodontal membranes, those are small, tiny ligaments that hold your tooth in place. And so when you're wearing braces or Invisalign, okay, when they're trying to realign those teeth, you're influencing those tiny membranes there. And at the same time, depending on how long the actual alignment correction process is going in the individuals, you can slightly what's the word? I'm having a horrible time with trying to think of words today, y'all. You have to forgive me. You're going to pretty much remodel these joint spaces there, right? Because if you watch the video that I sent out on chapter 7, on the remaining material of chapter 7, mechanical stresses play a role in bone remodeling. And so if you start to shift things around in here, that's going to alter the mechanical stresses. And so the joints themselves can remodel. All right, so here you can see it. The Gomphoses is our very first fibrous joint here. And you can see the fibers that hold it into place. All right, these little periodontal membranes will attach the bone or the tooth itself to the bone here of the alveolar processes there. Okay. So next are our suture joints here. Okay. And so same type of scenario here, right? You're going to have bones held together, and in between the bones, you will have, all right, some fiber in there. But the nice thing about these joints is that they have like a zipper type of effect. Okay, these jagged kind of edges there that act like a zipper, but they help to interlock the bones with one another so you don't see a lot of shifting going on. And so eventually, as we get older and older, these joints will eventually fuse together. Some will fuse earlier than others, all right? Some will take quite a while. And I'm trying to think, there's a couple of the suture joints there in your skull that can take up to age 60. Some fuse together by age 40. All right. So once they ossified, then, all right, we refer to them as, all right, Syndesmoses. All right, so those are your suture joints. So we saw those in chapter 8 when we were studying the cranial bones of the skull. And then our final joint here are the Syndesmoses. And we didn't really get a chance to talk about the example here that you see in the picture here, but this is where you're going to see two bones, right, held together, right, by like a fibrous sheaths. And so you see it in the forearm and you see it down in the leg. So you have to have two bones that are parallel to one another, like the radius and the ulna on the forearm, or you have the tibia and the fibia down in the lower extremity. And so you'll have this sheet, this thick, dense connective tissue that connects the two bones to one another. And so what they do is they, prevent the bones from banging into each other because they hold the radius and the ulna at a fixed distance from one another. Because like it or not, you don't want the bones banging into each other. It doesn't feel comfortable, right? It does not feel good, especially if there's no cartilage there to absorb any of those movements there. So what it does is the interosseous membrane between the radius and the ulna, for example, when you do what we call, and we'll learn about this, hopefully you have time today, pronation and supination. That's when you do this with your forearms, when you're just basically turning your hands back and forth like this. This is called supination. This is called pronation. And so what happens is when the radius and the ulna are doing those movements, the radius, this bone right here, the radius will actually overlap and roll over on top of the ulna during pronation. So when you're in the anatomical position, you're in a supinated position. Your palms are facing forward. That's called supination. So when the palms are facing forward, that means the radius on the lateral side and the ulna on the medial side are parallel, just like in that picture there. And then when I go into pronation, simply by me turning my palms like down, or if I'm in the anatomical position, I just turn my palms backwards. Just by doing that motion, the radius bone, this is my left arm is the ulnar bone, my right arm is the radius bone. During pronation, the radius will literally cross over, all right? But that intraosseous membrane keeps them from banging into each other, and it keeps it at a fixed distance there. So anyways, point being is, this type of joint here, there is a limited, very little movement there, right? But think of it as acting as a pivot point, right? So it is classified functionally as an ampharthrosis, which means it has a little bit of movement there, because you will get a little bit of movement there. Okay, So that was for Syndesmoses. Now we've got our cartilaginous joints here. All right, so the first group of joints were the fibrous, and we had 3 types of joints there. And now the next grouping are the cartilaginous joints here. And so, like the name says, there's going to be cartilage somewhere. So you're going to have either hyaline cartilage or fibrocartilage between the bones that make up this joint. Again, we have no joint cavity. And so these types of joints will either be immobile or they'll have a little bit of movement there. And so there's 2 types. And you've seen these, right? We just got done talking about the pubic symphysis. So that's a Symphyses joint. So you have a Synchondroses, and then you also have a Symphyses type of joint. And I'll run through these with you here. Okay, so again, keep in mind, cartilaginous joints involve bone and cartilage of some sort. So let's see the examples here. The first one here are the Synchondroses. So this is that joint, right, that we see between the ribs and your costal cartilage, which is a hyaline cartilage. Also, your growth plates, believe it or not, that is actually considered a joint. You can get very minimal movement there, right? We don't really want it there. We want it at the actual joint space itself, but you can get a little bit of movement there in the epiphyseal plate there, in the growth plate. So again, we're seeing both cartilage and bone being involved in those areas. And so a Synchondroses is a really great example of a hyaline cartilage type of joint. So the other type of cartilaginous joint is going to be the Symphyses. And so these joints we see in more weight-bearing areas, right? Places that have to undergo a lot of compression. So the spine is a perfect place for that. The intervertebral discs are going to be those areas where we're going to see a lot of compressive forces. And then the pubic symphyses, that little disc there that sits anterior in the front of your pelvis, in between the right coxal bone and the left coxal bone there. Again, big point of this type of joint is it's going to be made up of fibrocartilage. So we're going to see lots of compressive of forces acting on that area there. And so these joints are there, all right, to help with shock absorption, all right, but we'll see a little bit of movement there in these types. So therefore, we call them, if you have slight movement, ampharthroses. So talking about, since we're discussing the cartilaginous joints, but specifically the costal cartilage joints, the joints between the ribs, has anyone ever heard of costochondritis? Costochondritis usually seen in older patients. So you'll get an older patient that comes in, or a person that will come in, and they'll complain of chest pain. God forbid it's on the left side, because what are they thinking? Heart attack, right? Yeah, exactly, right? But usually it'll be localized to the front part of the chest, and it's usually going to be in the upper ribs there. So usually ribs, I've seen it most commonly between ribs 2 and 7, right? And so again, you'll have this localized chest pain. You know, they say it's an idiopathic etiology, which means we really don't know, but most likely it's between trauma and infection. And I've seen it more with trauma. Most people have been overexerting themselves, doing a lot of activity, you know, especially now you're seeing a lot of folks doing yard cleanup and things like that. Well, anyways, it's a joint just like anything else. And if that joint gets irritated, it becomes inflamed. And when you get inflammation, you're going to get pain. And so we're going to see that inflammation around those costochondral joints there. And so an easy way to rectify it is recommend non-steroidal anti-inflammatories, NSAIDs. All right, let's just see if that helps. Put some ice on the area. If that's still not helping, usually what I will recommend, it happens very, very rarely, I will recommend a steroid. If that doesn't help, then we're taking x-rays or MRI because it might be something more than costochondritis. But that's pretty much how costochondritis presents. And you'll see it just on either side of the sternum, right there where the cartilage, all right, kind of meets the sternum. And so any type of irritation to that, costochondritis. All right. So let's look at the other type of joint here that we talked about, the diarthroses joints, which are called synovial joints here. Synovial joints, and we're going to spend a lot of time on talking about these because they are the most numerous type of joint in the body. So a synovial joint is going to be a joint that has a capsule that covers the joint. And so inside that capsule, we have the bones articulating with one another, but you also have a joint space. And in that joint space, you have fluid floating around. So these joints are diarthroses, which means they are freely movable. So if you look at the characteristics there, you're going to have a joint capsule and a cavity inside filled with synovial fluid. You're going to have bones articulating with one another, but what covers the ends of those bones are going to be that hyaline cartilage that we call articular cartilage there. And then within the joint also, right, because we're including the joint capsule, we're going to see blood vessels, we're going to see tendons, we're going to see ligaments, right? And we're also going to see nerves. So you're seeing in these types of joints, lots of different types of tissues, right? So synovial joints, right, play a big role, right, in most of the movement in your body. So it only makes sense that we want to make sure that one, these joints are well innervated, because when you get into later chapters, we're going to learn about proprioception, balance. And so you've got lots of special receptors around these joints to tell your brain where things are in space with your body. And then we'll also see lots of blood vessels because a lot of movement there requires, all right, us taking care of the tissues that are creating this movement. So the blood vessels are going to provide nutrients, and it's going to also take away waste from those tissues there. So here you can see a nice picture here of a synovial joint. I'll even zoom in a little bit. So you'll notice, again, you have in this picture, the two bones articulating with one another, and their epiphysi are covered with that hyaline cartilage called articular cartilage. So what are two of the functions that articular cartilage is providing to the joint? What do you think? Did you say friction? Cushioning. Well, yeah. Shock absorption for cushioning and reducing friction. That's its two jobs there, right? If you don't know it, make sure you know it, right? So articular cartilage helps to reduce friction, so we're not damaging the underlying bone. And then it's also going to act as cushioning for shock absorption there. All right, so now we also see we have this cavity, this space here, and that's filled with the synovial fluid. And then you'll notice surrounding the joint itself, you have this capsule here. And we'll talk about the different parts to the capsule. You have this outer part here that is going to be made up of dense connective tissue. And that's going to be the fibrous layer. And then you have the inner part that lines the internal portion here, right, of the joint itself. And that's going to be the synovial membrane. Because remember, we learned that there was 4 membranes in the body. Serous membrane, right? Then we also learned about the cutaneous membrane, that's your skin. Mucous membranes, which we don't talk about too much in this course. And then finally, the last membrane is the synovial membrane, right? And so we'll talk about the purposes here of the synovial membrane. But let's take a look here at the articular capsule here, right? So I said that you have the outer fibrous layer, and that's our dense connective tissue. And we talked about the wonderful characteristics of dense connective tissue. It's strong, so it provides stability to a joint, right? It helps prevent joints from being dislocated or subluxated, right? And so they add that stability there. And then on the inside there to our outer fibrous layer, we have the inner synovial membrane. And it's made up of a loose connective tissue. It's made up of areolar connective tissue. And so it's going to line the entire inside surface of the joint, right, except where you see articular cartilage. So it'll line everywhere except where there's articular cartilage, because think about it, it doesn't make sense to line, all right, the inside of your joint with the synovial membrane on the articular cartilage, because those bones are going to be grinding away on each other. And so you damage the synovial membrane. So we don't put the synovial membrane over the articular cartilage there. Right? And so it's the synovial membrane that is going to produce our wonderful, wonderful synovial fluid here. More on that here in a few moments. Okay, so there's our joint capsule. Okay, outer fibrous, inner synovial membrane. Then we have our articular cartilage in the joint cavity space there. And so that lines the end bones, made up of hyaline cartilage. Right, so like I said, it's going to reduce friction. It's going to act as shock absorption there, and it literally protects, right, the underlying bone there from damage. Because over time, that articular cartilage can wear away, especially in weight-bearing joints, like knees, for example. Right? They're commonly associated with the wearing away of that articular cartilage. And so eventually what happens is you get bone, you hear terms like bone on bone, and you'll get people's bones just grinding on one another. One, it's painful, and two, it causes abnormal bone growth in regards to the body trying to repair itself. So you get a whole list of issues there. Now, we learned back in chapter 5 that the 3 cartilage types, 2 of those 3 cartilage types have a perichondrium, and that was fibrocartilage and hyaline cartilage. Well, guess what? There's an exception to the rule here, and here it is, one of those exceptions. This hyaline cartilage, this articular cartilage, does not have a perichondrium. Right, so it is one of the exceptions to the rule, but normally hyaline cartilage does have perichondrium, but this one doesn't. And of course, as we know, all mature cartilage is avascular. So this cartilage has to get its nutrients and get rid of its waste through the process of diffusion. And we're familiar with that. Right? We're very familiar with diffusion. And so what helps facilitate diffusion in articular cartilage is movement. That's why we're always telling people, ask any physical therapist, they're always encouraging movement, move that joint. Don't let it just sit around, all right? Don't let it be immobile, because that's a problem. When we used to do joint replacements, if you got a hip replacement or a knee replacement, you were in bed for several weeks. Now, they're getting you on your feet the day of the surgery, if they can, for your knee and hip. And they found that it does better, right? And so because of some of the concepts that we'll talk about, right? But part of it is we want to make sure, right, with the articular cartilage, because there are avascular tissues in that area that we just replaced that joint with, we've got to make sure we're getting nutrients to that tissue there. Okay, so we've talked about the joint capsule. We've talked about both the inner and outer layers there. We've talked about the articular cartilage. Now about the joint cavity itself. It is a space filled with synovial fluid. Synovial fluid is thicker than water, so it's going to have a little bit more of a viscous type of composition to it, almost like engine oil. If you've ever seen motor oil or touched motor oil, right? It's going to be a little bit like that. And so synovial fluid is going to play a couple different roles. One, okay, remember our tissue, the articular cartilage is avascular, so it needs to get nutrients. Well, guess what? The synovial fluid helps with that. It is going to help to lubricate the articular cartilage, right? It helps to keep that tissue healthy. It also acts as a shock absorber, right? Much like you see shock absorbing properties with articular cartilage. Well, the synovial fluid also does that. And like I said, all that tissue, that articular cartilage is avascular, that mature cartilage is avascular, it does not have a blood supply, so the synovial fluid is going to help provide, right, some of those nutrient components, and it helps to take away waste products, right, from those cells there. All right, so it's kind of a nice little system that they have, right, this little ecosystem inside of our joints. Well, specifically inside of our synovial joints there. Okay, so what do we call the tissues that hold bones together? Ligaments, that's right, okay? So a lot of your joints are going to have ligaments that are going to be part of the joint capsule altogether. And so let's talk about some of those ligaments there. Keep in mind, we learned in chapter 5, ligaments are dense, regular connective tissue. You need to know that. Dense, regular connective tissue. So the job of the ligaments is to hold bones together, but they provide, their main function in that job is stability, right? Stabilize the joint, strengthen the joint, and make sure that abnormal biomechanical forces are not working on or acting upon the joint. So you have 2 types of ligaments. You've got the extrinsic ligaments and the intrinsic. So extrinsic is going to be the ones that you can, when you're dissecting a cadaver, you would be able to see these ligaments separate, right? They're easy to identify. The intrinsic, harder, because a lot of those ligaments will be part of the joint capsule, right? So you'll just see parts of that joint capsule are thickened, and that's because the intrinsic ligaments are contributing to that, right? So the extrinsic are physically separate from the joint capsule itself. The intrinsic will become part of the joint capsule there. It doesn't mean that, you know, some of those intrinsic ligaments can't originate from outside of that joint capsule, but they'll eventually fuse into it. But the big thing is, I want you to really know the purpose of our ligaments, and that's for those stabilization, strengthening, and reinforcement there. All right, a couple other things here that we'll see in our synovial joints: nerves, blood vessels, mainly sensory nerves, right? And so we'll talk about these later on, right? But the sensory nerves are going to do a couple things. One, obviously, one's to detect painful stimuli, like if you're overstretching a joint, for example, or if you get hit, right? That joint takes a hit, like in football or whatnot, right? But the nerves play a large role, because, especially the sensory nerves, because they're going to provide a lot of what we call biofeedback. If you're moving incorrectly, they'll tell your brain, and then your brain will try to correct those movement patterns there. And a lot of the nerve receptors that are responsible for that are called proprioceptors, also called mechanoreceptors. We'll learn all this in later chapters, all right? But I want you to know this right now. It helps with the movement of that joint, so you don't overextend a joint or flex too hard at a joint, right? It's all designed to protect you and keep you safe. So you'll see lots of sensory nerves and blood vessels in synovial joints there. We're all familiar with what tendons do, okay? Tendons are going to actually attach muscle to bone. And by doing that, they also, ask any physical therapist, right? Your muscle tone can help with joint stability. And in fact, most people that I've talked to that have gone and gotten a knee replaced, their doctor recommends that they start to do strengthening exercises for the muscles in their leg. So the quadriceps muscles, the hamstring muscles, the gastrocnemius, or the posterior calf muscles. They're telling those folks to strengthen those muscles, because that helps to stabilize the joint. So when they get the brand new knee, now they have a somewhat stable knee joint, all right, prior to the surgery. All right, so tendons, again, as you know, attach muscle to bone, but they do play a stabilization role here. But keep in mind, good true or false question, it is not part of the synovial joint itself. Okay, it does not play a role in that. So is anyone familiar with bursitis? Anyone have heard of bursitis? Okay. So most of you shouldn't be familiar with it because you're not old enough to be, right? Normally we see bursitis in older patients. So what is bursitis? Well, bursitis is going to be an inflammation of our bursa sacs here. So bursa sacs are just that. They're these sacs, right, that have this fibrous, all right, outer material on the outside filled with synovial fluid. And you'll see them all around certain joints. You'll see them by ligaments. You'll see them by tendons, all right? You'll just see them in areas that are undergoing a lot of movement or physical stresses there. And so their job is primarily to decrease friction. And so anyways, I bring up bursitis because as we get older, the fibrous lining to the bursa becomes thinner and thinner. And so it becomes much more easy to irritate. And so you'll see it in our older patient population, because if they're a person that sleeps on one side the entire night, and if they do that regularly, they're aggravating their bursa sac, and their hip might start to hurt. So they start to come in and complain of hip pain, all right? That usually affects them when they're laying on their side, but when they're sitting and walking, it doesn't bother them. So normally that's going to be a sign of bursitis, not always, but normally. And so again, the bursa sacs are just these fluid-filled synovial sacs that you'll see that sit around, right, various areas of the joint here. And so you can see here, right, we've got a couple bursa sacs in and around, all right, the patellar ligament here. You'll see it on the back side here around some of the knee joint. And this is not even showing all of the bursa sacs that are around your joints. But you have them, think of any joint that has quite a bit of mobility, and you'll have bursa all over the place there. All right, then we've got our tendon sheaths and fat pads. Again, a lot of times, right, there's a lot of stresses are occurring at these joints, so we want to minimize these joints. So one of the purposes, I'm going to go and talk about fat pads first, and I'll come to tendon sheaths. One of the purposes of fat, right, we talked about the functions of fat: energy storage, cushioning, right, and insulation. Well, in this case, our fat pads are going to act as cushioning. So they will act as that protective packing in and around joints, right? So things aren't banging into certain tissues there, right? And it's providing, right, a cushion-like environment to decrease compressive forces, any shearing forces, other types of forces, not so much like shock absorption, because that's what the cartilage is for there, but when tissues are sliding by each other and moving around each other, right, fat pads play a big role. And I'll show you a picture here of the tendon sheath, but tendon sheaths are just these big, long, elongated bursa sacs. Same thing. They're going to, like the name says, tendon sheath. It's going to ensheath itself around a tendon. And again, it is going to play a role in reduction of friction, right, in specifically your wrists and ankles. So this picture here shows beautiful tendon sheaths here in your wrists and in your fingers here. So again, think about how much you are moving your fingers all the time, especially if you're typing, right? So when you create that movement, you create friction. And so these tendon sheaths help to reduce friction so we don't damage tissue there. All right, now we're going to move on to another part of the synovial joints, and we're going to talk about their movements. So we're going to talk about how we classify their movements here. All right, so classification of synovial joints, and we're going to discuss, right, how the movements occur basically due to the shape of the joints there. All right. So the three types that you have listed up there: uniaxial, biaxial, and multiaxial. So again, just dissect the word. Uniaxial means we're going to move a joint around one axis or a plane. And we know the planes now, right? Is it going to be through the coronal plane? Is it going to be through the mid-sagittal plane or the transverse plane or the XYZ axis, whatever, however you want to describe it. Right? So that's what we're saying. So uniaxial, one axis or plane; biaxial, two axes or planes; or multi-axial will be multiple planes or axes. Right? So you can probably guess that as you move from uniaxial to multi-axial, you'll see, right, some differences in the types of movements, but most likely you're going to see an increase in the range of motion or movements there. So I want to go through and talk to you about some of these movements here when we're looking at these joint types. So this next slide, right, talks about, right, when we're looking at how to classify these movements, we're going to do it based on the shape of the joint surface. Right, so what does that joint surface look like? So you can see we have 6 different types, right, of classifications or classes, I should say. So the top of the page is the least mobile, the bottom of the page is the most mobile. So plane, hinge, pivot, condylar, saddle joints, and then ball and socket joints. So those are going to be your 6 classes, and I'm going to walk you through these. We're going to go through these. We'll spend more time on the more mobile joints there. All right. So the first one, like you would guess it to be, a plane joint. Both surfaces are going to be flat. I'll show you examples here in a second. All right. So a plane joint, both of the joint surfaces are flat. Very basic joint there. And so it's going to be uniaxial, which means we're going to move those bones in a single plane. Either they'll move in the coronal plane, they'll move in the transverse plane, or the mid-sagittal plane. So the next one is a hinge joint. Well, we all should be very familiar with that. Right? You should think of a hinged door, or your elbow, for example, as a hinged joint. So in this case, you're going to have a convex surface, which is this kind of surface here, curved surface on the outside here. That's a convex surface, right? And then that's going to articulate with a concave surface. So this guy right here, this is the concave surface right there. Okay, so the convex surface is going to articulate with a convex depression. And so just like you would see with in your elbow joint, your knee joint is another hinge. It's a modified hinge because there's a little bit of rotation in your knee. But it's like a door. Okay, just think of how a door operates, and that's how these joints operate. All right, a pivot joint here. Right, this one here, right, you're going to have a rounded surface of the bone is going to fit into a ligament ring. Now, we didn't really talk about this too much in lab, but we did mention that in chapter 8 when we were learning about the axial skeleton, and we started on to the spine. We learned that your first two vertebrae, the atlas and the axis, right, they operate on a pivot joint because you have the dens or the odontoid process of the atlas, which is that like projection that comes straight off the top of the bone, and then the atlas sits right on front of that, and the front of the atlas, that bone, sits on top of the dens process there. And then there's well, let me just show you. Here's the top of the dens or the odontoid process. Here's the atlas, the front of the atlas coming over. And then you have this big ligament ring that attaches from one end of the atlas, surrounds, goes behind the dens of the odontoid process and attaches onto the other. And so it'll pivot, it'll just swing around on that. And so that is the pivot joint. The C1 and C2 is a perfect example of that. All right, the fourth type of synovial joint is the condylar joint. All right, this one is a biaxial, so it moves in two planes here. But again, you're going to have an oval structure, something that's convex, articulate with a concave substance or surface here. And so this is going to be more biaxial. It can move in a couple different ways, right? So think about your mandible, right? That's more of a hinge joint there, but you do have a condylar surface there. I'll find you a better example there. Saddle joint, convex and concave surfaces again, but this time, if you've ever ridden a horse, it will look like a saddle. And so the nice thing about these types of joints is that they're biaxial, can move in more than one type of plane of movement or axes of movement. And then finally, we have the ball and socket. These are the most mobile type of joint here. And so they can move in all of the planes or axes here. And just the name of it tells you exactly what it looks like. You have a ball, right? And then you have a cup. And so that ball fits right into that cup. Right? Your hip joint is a perfect example of that, the femoral acetabular joint, where the head of the femur, right, articulates with the acetabulum. We all know what those things are because we learned them last week. Right? And so that's a perfect example of a ball and socket, right, joint. So in these joints, now that we've talked about how these joints are classified and how they're kind of put together, now what we got to do is talk about their moving. So when we're talking about movements, all right, one type of movement is gliding movement. So you have two surfaces, right, that are articulating with one another. And so one surface is going to move past the other. And so it's going to do so in a gliding motion. It can either move side to side, up and down, whatever, right? But it's going to move in a pattern, right, back and forth in one direction or up or down or side to side. And so the only problem is it's limited, and we can move, all right, in any direction, but it is limited, so we won't see a lot. So perfect example are carpal bones, right? The proximal row of carpals moving on the distal row of carpals. They just do a gliding motion there. Now, each bone by itself doesn't project a significant amount of motion, but when we add all the motions for all the bones in those joints moving, we'll start to see a much larger overall movement pattern there. And we'll speak to this here shortly. Now, this picture is not very good because I don't know why, the detail just did not come out very well. But this is kind of showing you some of those different, here you can see a plain joint moving, sliding back and forth. You can't even read some of these, but here's your hinge joint here, all right? Nice ball and socket over there. Well, I'll show you some better pictures anyways. I should just get rid of that picture altogether. All right. So let's talk about the different movements that now we're going to view in a synovial joint. The first one we already talked about, which was the gliding, okay? Two opposing surfaces moving back and forth, right? Then we have angular, rotational, and then our special movements. And we'll talk about the special movements because those are those named movements that we're not terribly familiar with. And we'll discuss those. You know, there's special names like pronation, supination, like I was talking to you about earlier. Plantar flexion, dorsiflexion. We'll talk about, all right, some of those here. All right, so those four types. We talked about gliding, so I'm going to skip past that and get into the angular here. All right, now this is the part that might interest some of you when we're talking about angular motion, because we're now going to learn about certain terms, right? Like flexion, extension, lateral flexion, abduction, adduction, all these different terms that you may have heard. Or if you work in a doctor's office, they may have used some of these, especially if it's an orthopedist doctor's office there, okay? So the definition of angular motion is going to be when motion occurs, it's either going to increase or decrease the angle between the two bones that make up that joint. So for example, we now know all the bones that make up your elbow joint. You've got your humerus, right? In your arm, and then you've got your radius and your ulna in your forearm. And so and we'll go through these motions, but an example of flexion, when I flex my elbow, when I bend my elbow, I am now making the angle, that's this measurement area right here between your forearm and your arm. Now, as I flex my arm and bend my elbow, this angle becomes smaller and smaller and smaller. All right, and that's what flexion does. And I'll go through this. That's what we're talking about, the angle between the bones there. Okay, so when we're talking about that angle, it's either going to increase or decrease. So speaking of flexion, let's talk about it. Okay, so when we're discussing flexion, keep in mind, we're moving in what we call the anterior posterior plane. What does that mean? Front to back. Okay, so front to back. So when I flex something, like that example that I just showed you, if I flex my elbow, then I'm going to decrease the distance between the radius and the ulna, right? Between those two bones and the humerus, right? When you go to make a fist, that's what happens with your phalanges, right? When you make a fist, you're flexing and bending your fingers there. The phalanges get closer together. The angles, right, between the phalanges get closer together. So flexion of my elbow, bending my elbow, I am doing this. Then when I go and do the opposite, I do extension, right? Extension is the opposite. So we're still moving in the same anterior posterior plane. We're still moving front to back, right? In this case, I am increasing the angle. So after I asked you to make a fist, I said, okay, all right, now what I want you to do is instead of having your fingers bent, now go ahead and reach out to somebody and try to shake their hand. When you go and extend your hand out to shake their hand, your fingers are now in the extended position, right? When you go to make a fist, they're in the flexed position. Same thing with your elbow. When I bend my elbow, I'm in the flexed position. Then when I go to straighten my elbow out, I'm extending it. Why? Because look, the angle between my forearm and my arm is now becoming bigger and bigger and bigger and bigger. And that's the definition of extension, right? Increase the angle between the articulating bones. All right, so that's flexion and extension. So if I were to say, hey, flex your shoulder, you would do this. If I say extend your shoulder, you would do this. All right. So if I say flex your hip, you would do this. If I say extend your hip, you would do that. All right. So that's flexion and extension. So that leads us into hyperextension. Now, hyperextension, the term that you've probably heard a lot is like somebody hurt themselves. They hyperextended their elbow, or they hyperextended their knee. That's that is a different definition for hyperextension. But in anatomical terms is when we, all right, increase the distance between our two bones, or however many bones we're discussing, more than 180 degrees. Right? So we're used to hearing it in this definition, extension beyond the normal range of motion. Well, yeah, if it's beyond the normal range of motion, then you've probably strained that joint and you probably injured it. In this case, what we're talking about with hyperextension is you're moving it past that 180 degrees. And I'll show you an example here. Well, let me just flip to this page here. I'll come right back. So this picture here that's in your book, you can see the gentleman here, when he's in the anatomical position, he's looking straight ahead. And so now we're going to ask him, all right, my friend, we want you to flex your head. So he's just going to look down towards the floor. So he has now decreased the distance between his cervical vertebrae and the sternum, for example. Those are going to be your two reference points there. So now we say, okay, sir, thank you very much for looking down at the floor. Can you look straight ahead again? When he goes from the flex position to the extended or to the upright anatomical position, looking straight ahead, when he's gone from the flex position to the upright position, now he's moving into extension. But now we say, all right, buddy, we want you to go ahead and look up towards the sky as far back as you can. And now he's extending his head way back like that. That's the hyperextension. He's exceeded that 180 degrees, because this is 180 degrees, him looking straight ahead. And then if he goes from this flex position all the way back, that's more than 180 degrees. Okay. All right. So that's an example of hyperextension there. All right. Lateral flexion. Now we're going to deal with a different plane here, the coronal plane. Y'all remember the coronal plane? That's the one that will divide your body into anterior and posterior parts. Okay. Essentially, you're chopping a person into a front half and a back. I won't say half, but because it could be unequal, into a front part and a back part here. So what happens is we move in that plane. So lateral flexion, a perfect example of lateral flexion is, for cervical lateral flexion is, I ask the person, I want you to take your right ear and try to touch your right shoulder with your right ear. So they do this, right? That's lateral flexion, okay? Or you do it to the other side, right? So what we'll see that most often in the spine, so if you ask somebody, all right, while they're standing, please lean to your right as far as you can. We're going to see how much lateral flexion they have in their lumbar spine. And then we'll have them go the other way. And so normally with lateral flexion, we involve the trunk somehow. So that's what you see here on this page here, all the way to our right. You can see this person going into left lateral flexion. They're leaning to the left side there. And so they're flexing the lumbar spine to the left. Here's another example of flexion and extension. When you ask somebody to flex their knee, just bend their knee. And then when you ask them to straighten out their leg, they're going into extension there. Right? The wrist here is another example of flexion, extension, and hyperextension. So again, when your wrist is straight out like it is here, or in the anatomical position, when you ask them to flex their wrist, they're going to bend their fingers forward. And then when you ask them, all right, go ahead and put your hand back to the beginning like you're going to shake someone's hand, the wrist goes back into extension. And then when you bend your hand back, all right, that's hyperextension. And you can see the same here for the elbow, flexion versus extension. Okay, so the next type of movements are abduction and adduction. Sometimes I'll say abduction and adduction, so you know what we're talking about. Are you guys good with synonyms? Words of similar meaning? What do they call it when somebody gets kidnapped? Abduction. There you go. They get taken away, right? That's what abduction is. So when we think about abduction, we're going to move something away. So we're going to move whatever body part we're talking about away from the midline. What's the midline? Your axial skeleton, your spine, the center of your body, right? Your sternum is going to be midline there. So when you abduct something, like if I'm going to abduct my upper extremity, right? If I abduct my shoulder, I'm going to do this. I'm going to move it away. See how my hand is moving away from the midline of my body? It's going away. That's abduction. Adduction is, okay, you've done abduction now. Now bring your arm back down to your side. And now I am adding it. How I remember it is I'm adding it back to my body. right? So abduction, we're moving the body part away from the midline. With adduction or adduction, we're moving that body part back toward the midline. All right, so check it out. Here's that lady. She's doing abduction. She is lifting her shoulder away. Her arm goes out and away. That's AB or abduction. When we ask her to bring her arm, please, back down to your side, that's adduction. Wrist is a different story here because now what we're going to do is we're going to use the reference point is not so much the midline of the well, it is the midline of the body. I'm thinking, oh no, hold on. We'll get over here with the fingers. So wrist abduction and adduction, same type of thing. When we move the wrist towards the midline of the body, that's adduction. When we swing it away, that's adduction. Hip, same type of thing. We move that body part away from the midline, abduction. When we bring it back, adduction. With the fingers, different story. Your middle finger now is considered the reference point. That's the midline of the hand. So your third digit would be, all right, the reference point. So if you ask somebody to open their fingers up, that's going to be AB or abduction. And then when we bring our fingers together, that is AD or adduction. Okay, so the last part of our angular movements is going to be this one, circumduction. So just think of a circle. We all did it when we were in PE class, when your teacher was saying, all right, everybody do some warm-ups and do arm circles, all right? And so that's essentially what you're doing, all right? When you're doing those arm circles going forwards and backwards there, right? You're going to, the proximal point will kind of be like your anchor point here, your point of axes. And then the distal part, you're doing arm circles, which would be your fingers and all that, right? That'll be the larger part of that big old cone, all right, that you can see that this person is creating when they're doing circumduction. All right, so the proximal end is not going to be a lot of movement there. That's going to be relatively stationary. The distal end is going to have most of the movement there, but it's going to make that cone-like shape and configuration there. So that's for the angular motion. The next type of motion is called rotational motion. Right, and so rotational motion, we're going to talk about a couple different movement types, right? But here we're going to be rotating the bone along what we call its own longitudinal axis there. So you'll see 4 terms up there. I briefly talked about pronation and supination, right? But you have lateral rotation, medial rotation, pronation, and supination. So lateral rotation, now here's the thing, you've got to understand the definition of these terms to understand how they work. So for lateral rotation, turns the anterior surface of the bone laterally. So this is all based on the anatomical position. So you have to imagine how the bone appears in the anatomical position. So for example, let's use the humerus here. I'm in the anatomical position. So the humerus, that portion basically where your biceps brachii sits on top of. All right, so now if I want to do lateral rotation, that means I want to turn the front part of my bone out. So this is an example of lateral rotation, me doing this. This is see what I'm doing? See the front of that bone is going to be turning laterally. That's lateral rotation. And then medial rotation would be bringing it in. So the anterior surface then turns in. Same thing with your leg, okay? So your leg, you ask somebody to laterally rotate their hip, they'll turn their foot out because the femur, the anterior surface of the femur, turns out. Medial rotation, okay? So always keep in mind where the anatomical surface, excuse me, not anatomical, well, yeah, the anatomical surface, but the anterior surface specifically. So for pronation and supination, this again has to do with the forearm and the palms. And so keep in mind, if you know when you're in the anatomical position, you're in the supinated position. Palms are facing forward, right? How somebody reminded me or kind of explained it to me with supination is, if you put your hands together, that's how you hold soup. If you were going to have soup out of your hands, so your palms are forward, they're they're upright. All right. Now, all I'm going to do for pronation is I'm going to turn my palms posterior, backwards. All right. So that is pronation and supination. So keep in mind, supination, hand is anterior, like in the anatomical position. Pronation, hand is posterior. Easy to remember, posterior P, pronation P, right? So let's take some pictures here. Here you can see, right, with just general rotation, if you ask the person to look to the left or the right, if they look to the right, that's right rotation. If they look to the left, that's left rotation. And then here you can see with the medial and lateral rotations, just look at the anterior surface of whatever bone that we're going to be moving. So this, in this case, it's the humerus. So when this person moves their forearm out, that's lateral rotation. When they bring it across their body, that's medial rotation because the anterior surface is now pointing in. All right, same thing here with lateral and medial rotation of the hip. And here you can see a nice example of pronation and supination here, right, with the forearm. Palms forward, that's going to be supination. Palms posterior facing, that's going to be pronation. And just keep in mind, in supination, both your forearm bones, both the radius and the ulna, are parallel to one another. In the pronation position, the radius has crossed over on top of the ulna. Okay, so that's it for rotational movements. Now we got to talk about a few of our spatial movements. Okay, there's a couple here. So these are just all the ones that didn't fit into those other categories that we were talking about. So depression and elevation, just like that term means. When you depress something, you're going to lower it down. When you elevate something, you're going to lift it up. So depression, right? Let's look about in your skull. The only mobile bone in your skull or movable joint in your skull is the temporomandibular joint. That's your jaw. And so when someone asks you to depress your jaw, you're going to open your mouth. And then when they ask you to elevate your jaw, you're going to close your mouth. Another way to think of it is your shoulders. Okay, when you lift your shoulders up, that's elevation. When you push them down, that's depression. Okay, so depression, you're going to move the inferior body part. All right, it's going to move downwards, and then elevation, you're going to move that body part superior wise. So here you can see this guy with his depression and elevation, shrugging the shoulders. Shrug them up, elevation, push them down, depression. All right, now we got dorsiflexion and plantar flexion. This movement is located in one joint, your ankle joint. You don't have dorsiflexion and plantar flexion in your wrist. You don't have it in your elbow. You don't have it in your knee. It's only in your ankle. Right? So it only specifically has to do with, right, that joint that we learned about last class, the talocrural joint. That is where your tibia and your fibula, right, meet up with the talus. You all remember the talus there. So when you're in the anatomical position, your feet are flat on the floor, your toes are facing forward. All right, so that's our point of reference. So when we want to ask somebody to go into plantar flexion, I would say to them, hey, can you stand on your tippy toes for me? And that's what they'll do. They'll stand up on the balls of their feet. And they're actually going, when you're jumping in basketball to make a layup, that is plantar flexion. Right? You're going to be stepping off the balls of your feet there, and you're going to be planting your foot on the ground. And so what you do with plantar flexion is you're going to increase the distance between the top of your foot and your shin. So I'm in the anatomical position like this, so my feet are forward. If I go in, so the angle between the top of my foot and my shin here, around 90 degrees roughly, right? So when I go into plantar flexion, look, now I've just made that angle bigger, right? So my feet are coming off the floor there. Dorsiflexion, if you want someone to go in dorsiflexion, just ask them to walk on their heels, right? Try to walk on your heels. Try to bring the top of your foot as close to your shin as possible. And that is dorsiflexion. So again, keep in mind that those movement types are going to be specific for the ankle. Okay. The next type of special movements are going to be called eversion and inversion. Again, something that's pretty much in the foot. So when we talk about, and especially for those of you, if you've dealt with sports medicine, and if you've ever sprained your ankle, right? Normally they'll ask you, what were you doing when you sprained your ankle? Describe how that happened. I had a patient today that came in, and they were playing basketball, and he sprained his ankle. And even before he told me how it happened, I'm thinking it's probably an inverted ankle sprain. And then when I questioned him, he told me how it was. But let's look at what that means. What does inversion versus eversion mean? Well, if you look at the picture there of the foot, you can kind of see, all right, how you have, all right, think of the bottom of your foot, the sole of your foot. That's our reference point. So if you turn the sole of your foot inwards, all right, that's going to be an inversion movement. And then when you turn your foot out away from your body, that's an eversion, all right, movement. So just by looking at those two pictures there and what you know about your own body, what type of ankle sprain would you say is easier to experience, an eversion or an inversion? The inversion, yeah, there's better range of motion in that. And that's just, it's hard. I mean, I've tried, believe me, not to sprain my own ankle, but I've tried to get more range of motion in eversion for my feet. I just can't do it. It's just hard. You just don't have a lot just turning your feet outwards there. It's much easier to turn your foot inwards with the inversion there. So keep that in mind. That's eversion and then inversion. All right. The next are going to be protraction and retraction. And again, you can just look at the picture there. And so keep in mind when we're discussing the definitions here, protraction, the anterior movement from an anatomical position. So you're going to move, in this case, the jaw forward. You can do the same thing with the head, protract the head, retract the head, all right? But mainly pushing the jaw forward, that's going to be protraction. And then pulling the jaw back, all right, as far as you can, that's going to be retraction. So protraction, anterior movement from the anatomical position, and then retraction is going to be posterior movement, all right, from the anatomical position there. Not very easy to do, but still nonetheless. All right, so that's protraction and retraction. And then we have opposition and reposition. All right, so again, this is pretty much going to be for the thumb, all right, for opposition and reposition. And so keep in mind when we're talking about opposition, you're going to be, because we're one of the few primates that can actually do this maneuver, all right, you can take your thumb and touch your pinky with it. Right. And so that is going to be opposition. And then when you go ahead back to that anatomical position, when you pull that away, that is reposition there. Nothing really exciting about opposition and reposition. All right. Thoughts, questions about anything? Okay. I'm going to just talk about the temporomandibular joint here, and then we'll wrap it up here. All right. So has anyone here ever heard of TMJ or ever had TMJ, like a clicking, popping, painful issues with that joint, with their jaw joint? All right. So actually the definition of TMJ, or the proper definition, is the temporomandibular joint. But when we talk about the condition of TMJ, it's just referring to that joint there. A couple things that you want to know about this joint here. All right. One is, again, I've mentioned this before, only mobile joint between the bones of the skull here. But one of the things that I haven't really mentioned to you is that this joint also has its very own disc. And that disc is made up of fibrocartilage. And I know I harped a lot on, there's three places in the body that have fibrocartilage, right? And so this one is a fourth place, but I'm not going to keep listing off the places. All right, but it's this articular disc that can sometimes be the culprit in people that have TMJ, because this disc can move in inappropriate movement patterns inside of that articular capsule there and that joint space, and sometimes it can cause, all right, a clicking or a popping. And the reason why it can cause a popping is because we're dealing with synovial fluid, and one of the big components of synovial fluid is nitrogen gas. So when you pop your knuckles, be honest with me, when you pop your knuckles, do you think that what makes that noise is bones clacking against one another? I used to think that. Okay, good. Then you're all smarter than me, because I used to think that when I popped my knuckles, that it was the bones grinding against one another. It's not. It's the nitrogen gas that's in the synovial fluid. Okay, it's dissolved in the nitrogen in the synovial fluid, but when we do that cracking motion or whatever motion that we do to our joints to get them to pop, right, that movement briefly causes that nitrogen gas to come out of its dissolved state back into its gaseous state. And it usually that's why when you try to go pop that joint again, it doesn't pop, because it takes about 20 to 30 minutes for that gas to dissolve back into the synovial fluid. That's all it is. All right. So now you know how your joints pop. That's the reason why. All right. So when we're looking at the synovial joint, not the synovial, the temporomandibular joint, you got these two major ligaments here that are going to hold on to, all right, the mandible and hold on to the temporal bone here. Don't worry, I won't ask you what these are, to name these, but notice the names of them. They tell you the bones to which they attach to. I like it when anatomists do this, when they tell you, oh, spheno, all right, that's going to be the sphenoid bone. Mandibular, that's going to be the mandible. So they'll tell you, all right, which bones that these ligaments attach onto. Temporal and mandibular, same thing, temporal bone and the mandibular bone there. So these ligaments tell you to which they attach onto. Primarily, the main movement, all right, of our temporomandibular joint is going to be that hinge motion. Okay, so it's your mouth is opening and it's closing, but you probably noticed that you can slide your jaw from side to side. All right, that's important for chewing food, especially when you're using your molars to grind food. I'm sure that some of you have probably seen cows. You ever seen a cow chew its cud? Just stands out there in the field and its mouth is going all around and all that. I mean, that's what it's doing. It's just grinding down that food. And so that's the muscles that we have, right, that help to make up the temporomandibular joint movements, right? They allow for us to, one, open and close the mouth primarily, for chewing, right, but also side to side, right, for grinding and mashing that food up there. All right, so here's a nice picture of what I'm talking about. You can see in our little, hold on, let me zoom in. You can see on the left side of our screen, here you have, all right, the two joints, not the two joints, excuse me, the two ligaments, all right, temporomandibular ligament, and you can see it's attaching from, all right, the temporal bone, all right, onto the mandibular bone there. All right, and then you can see over here, the sphenomandibular ligament, again, it's attaching onto, all right, the mandible here, but you can't really see it, but it also attaches up here onto the sphenoid bone. Right. But what I like about this slide is this picture right here. Now you can actually see inside the joint, there's that articular disc there in between, right, your temporal side of the joint and the mandibular side of the joint. So you have this nice disc in there for shock absorption, compression. That is very helpful, because if it wasn't like that, I think we'd all be having a lot more serious complaints for TMJ at an earlier age. The fact that we have that disc in there prevents us from having it like in our teens and 20s. Okay, so temporal mandibular joint disorders here. Just talked about that when folks talk about the clicking and popping. And of course, I deal with some of that in my own practice, but of course, I always like to defer to people that are a lot smarter than me. So I've talked to several dentists in regards to this condition as to what they do, because it's a very difficult condition to treat, especially if you're not really sure what the cause is. And most dentists that I talk to don't like to treat this condition because it's tough. It's a tough condition. And there could be a lot of things that could cause it. If you're grinding teeth, has anyone ever heard of bruxism? That's grinding of teeth. And so if you're a teeth grinder at night, who knows, maybe you live a stressful life, and if you're grinding your teeth, it can cause this type of issue here, because it can cause that articular disc to move out of its normal position there, all right, just from all that tension on the joint there. All right, let's stop here